I'm going to hand it over to Dr. Weiner next. You've heard him speak. What we're going to do is review a case and use that case to structure an evidence-based review of the literature on COVID-19. And then we'll end with some final remarks from our colleagues in India again. Dr. Weiner, I'm going to hand over to you.
Thank you very much, Bhakti, and it's an honor to be collaborating with colleagues at AAIMS who I've respected for many, many years. So this is a case that I took care of about, as you can see, less than a month ago, or a little over a month ago. It's a 55-year-old unvaccinated man with a history of asthma who on June 5th was living at home, and his wife and his daughter-in-law were diagnosed with COVID. The entire house was unvaccinated, which is another problem, obviously, and they got it from one of their children who is at childcare, which is very, very typical about what we're seeing right now here. On June 9th, he developed typical fever, muscle aches, dyspnea. On June 14th, he was diagnosed as having COVID-19. And on June 16th, he was admitted to the outside hospital, a colleague of Johns Hopkins. And within about a day or so, he was on high flow nasal oxygen, requiring high levels of FiO2 between 60 and 100%. He was also found to have diabetes with a hemoglobin A1C of 8.7%, which he had never been treated for. He was started on appropriate therapy with remdesivir and dexamethasone. However, on June 23rd, he had gotten much worse, so that he was the hospital asked him to be transferred to Johns Hopkins. Our transport team went out to the outside hospital and felt that he was unsafe to transport on high flow oxygen. So we intubated him there and transferred him to the Johns Hopkins Hospital. His physical examination was normal. He had no renal dysfunction. His glucose was semi-controlled, not greatly controlled, but it was okay controlled. And at this point, he really did have single organ failure. Here are some representative cuts from a supine CT that was done when he arrived at Johns Hopkins. And you can see in all four cuts, the top left is the trachea is there, the top right is at the level of the carina, and the two bottom images are in the lower lobes. And you can see that he has the very, very typical presentation of COVID pneumonia with a combination of ground glass infiltrates, and then lower lobe and dependent, notably dependent consolidation. And those lower lobe consolidation areas are the areas that are going to be give us shunt physiology, which we'll talk about in a second. I would say that this CT scan is pretty appropriate for, hang on, don't put the poll up yet. I'm going to go one more slide. So before you answer the poll, I can't see this now. We put him on assist control ventilation with an FiO2 of 1.0, respiratory rate of 35, a PEEP of 12. His tidal volume was, I think, I can't see it right now, but I think it's 420 or something like that, 480. And at that level, he had a plateau pressure of 28 centimeters of water. Now, just to remind people, when I say plateau pressure, that is an inspiratory hold pressure. So it's a static measurement, no flow. We hold inspiration and we let the ventilator tell us what the inflation or plateau pressure is. That is the static pressure. With those settings, he had a blood pH of 7.28, a PCO2 of 64, and a PO2 of 98. These settings were based on the seminal paper from Brower, New England Journal 2004, which is referenced at your bottom. So my next question is, what is the next best step in the management for this patient? And now you can choose between inhaled vasodilators, a recruitment maneuver, prone positioning, increase the PEEP, or increase the tidal volume. And I guess we're going to give folks a second to answer. 2 people have. And it looks like, in the interest of time,
It looks like we're converging.
Here we go.
I see 60% favoring prone positioning.
That's great. And 27%, 25 to 30% want to increase the PEEP, and a small number want to increase the tidal volume. Thank goodness nobody wants to use inhaled vasodilators. And so far, nobody wants to use recruitment maneuvers. I think, Bhakti, for the interest of time, let's move on. Is there a way for you to get that out of the?
I did.
There. Okay, it's still showing up on mine, unfortunately. Okay, I'm going to go on. So, so exactly as 62% of you said, we did exactly that. We prone the patient. And initial settings were on, we kept the patient on the same setting. So FiO2 of 1.0, tidal volume of 480, which is 6 milliliters per kilogram of predicted body weight, respiratory weight. We did not change the PEEP, it's still 12. You'll see that the plateau pressure came down to 26, slight decrease, but notice what happened to the blood gas, a huge increase in the FiO2. That is classic for prone positioning. At the bottom here is the reference for the famous ProSiva paper, which showed in a randomized controlled trial that prone posturing improves outcomes and decreases mortality in ARDS. And I will point out that in the ProSiva trial, the minimum amount of proning was met, the goal was at least 16 hours. In our ICU, we prone for 24 hours. We change position, we do swimming maneuvers in the prone position, but we do not supinate for 12 out of 24 hours or even 8 out of 24 hours. If a patient is prone, we try, unless there's a contraindication or it's not being effective, we just keep the patient prone, is how we manage these patients. So what is the mechanism of improvement? We've already talked, everybody bought into prone improvement. I will say that in order to keep the patient prone, we did sedate him. And then soon thereafter, we did paralyze the patient, which we could talk about also. But what is the mechanism of improvement of prone positioning? This is a reference from a sheep study, but these studies have been done in many animal models and correlate exactly with what goes on in humans. And the bottom line is that prone positioning reduces shunt. And what you can see here in this picture is that when on the prone side on the right, the dorsal or the lungs that's back in the back of the lung by your spine is more blue, that is non-shunted areas, whereas in the on the supine position, that same lung, which is at the bottom here, and you can see my pointer, is behaving like shunt. Remember back to the CT that I showed a minute ago, where you saw all of that consolidation in the dependent dorsal regions of the lung in the supine position. When you flip prone, the theory is that you improve ventilation to those dorsal areas, and importantly, you do not distribute perfusion away from those areas. So the back of your lung retains its perfusion, improves its ventilation, therefore it will decrease shunt. Now, theoretically, you would expect the compliance to improve, and that also happens in most of these patients too, if you measure respiratory system compliance. So what about small tidal volume ventilation? I mentioned that we placed the patient on the evidence-based 6 milliliters per kilogram from the first ARDSNet study. But what about reducing that? I also want to mention briefly permissive hypercapnia, the best PEEP. And the other definition I'll give you here, I mentioned driving pressure already. Driving pressure, which is becoming a more prevalent tool for managing these patients, is the plateau pressure minus the PEEP. Remember, I mentioned it was that the plateau pressure initially in the supine position was 28 and the PEEP was 12. Therefore, the driving pressure is 16. Many of us believe that a lower driving pressure is a better way to ventilate these patients. So this is the reference that showed that volume controlled ventilation of 6 milliliters per kilogram with a target plateau pressure less than 30 and an FiO2 of PEEP from predetermined algorithms showed a almost 10% mortality benefit. This is the famous ARDSNet study. And this benefit was a 40 to 30%. However, one of the lost messages within this message is that it turns out these are data written from our colleague Dave Hager here at Hopkins, where when he analyzed the day one plateau pressures in these patients, he found remember the goal was to get in the experimental group was to keep the plateau pressures below 30. The patients who were above 30 were in the control or the group that did worse clinically. But the other thing he found out was that if you can get patients who had lower plateau pressures did better. So rather than thinking of plateau pressure of 30 as a threshold, we think it as an upper limit. And if we can safely get the plateau pressures lower, we strive for lower plateau pressures. That's our goal. And that's exactly what we did with this patient. So as I mentioned, on June 24th and 25th, he was prone and paralyzed. I actually turned his tidal volumes down to 4 milliliters per kilogram, which was a tidal volume of 280. I lowered his PEEP. I didn't raise his PEEP. And with that, I was able to get his FiO2 down to 0.5. Now, notice that I tolerate a large degree of respiratory acidosis. This patient's pH was 7.17 with a PCO2 of 85. And with that, he had a PO2 of 95. We actually went down to 40% oxygen on these settings. And for a while, it was variable. The patient did well most of the times. But so we were able to get his FiO2 down to 0.4 with a tidal volume that was this low. And you'll see that our plateau pressures were 18. Therefore, my driving pressure, which was 16 before, is now down to 10. I believe sincerely that this combination of a lower plateau pressure, a lower driving pressure, and I tolerate very high PCO2s. I do not treat these acidoses. And what's interesting is that this patient, you'll see 1 day later, he had normal renal function. His PCO2 did not change, but look what happened to his pH. His kidneys held on to bicarb, and he started adjusting for his own respiratory acidosis. Now, at this point, he still was paralyzed. The next day, we took off the vecuronium, we unparalyzed him, and we kept him on mild sedation. He was triggering breaths himself, and we allowed his tidal volume to go up to 5 milliliters per kilogram on sedation. And at this point, his plateau pressure went up only to 20 with this slightly higher plateau, with this slightly higher tidal volume. My point here is that I am judiciously allowing a little bit more tidal volume, but not too much. And I'm keeping my plateau pressure as low as possible. You'll notice that with that increase in tidal volume, his plateau pressure went up to 20, his PEEP was still at 8. We actually did PEEP trials where we raised the PEEP and we found out that he was not PEEP responsive at all. And that is a typical finding that I'm finding in patients with COVID. On June 28th, we liberalized him a little bit more to 6 milliliters per kilogram. We lightened his sedation even more. We did a spontaneous breathing trial. And on June 29th, essentially after 6 days of mechanical ventilation, we extubated him to high flow oxygen. So my teaching points for this case is that, and this is a really important point, early on in COVID, many people were trying to say that COVID-19 respiratory failure is not ARDS. No, COVID-19 respiratory failure is ARDS, and it should be managed just like all of our other ARDS patients. We start with small tidal volumes, less than or equal to 6 milliliters per kilogram of predicted body weight, and we utilize prone early. I mentioned before that I'm very permissive with my hypercapnia. I'll let pHs go down to 7.10 when we have a pure respiratory acidosis. I'd advise you to follow the plateau pressure. Lower is better. I adjust my PEEP by using driving pressure trials. So that is for a given tidal volume, I'll use my PEEP. I'll go from PEEP of 5, 8, 12, 15, 20. I'll look at what is the driving pressure, and I'll look for the combination of PEEP and tidal volume that has the best driving pressure, the lowest driving pressure, but still keeping my plateau pressures always less than 30. We've already talked about prone ventilation early, and I think the other key to good management is diligent ICU care, because we know that if patients develop other organ failures, they do poorly. This patient had single organ failure, only his lungs, and he did exceptionally well. Thank you very much. I'm happy to hear any discussion about this case. Now you're on mute, Bhakti.
Okay, am I unmuted now? Perfect. Thank you so much. I learned so much from you there. I'm going to ask our colleagues at AIMS Rishikesh for any quick reflections. Dr. Tripathi, anything that you would do differently or any quick teaching points that you would like to convey to our audience today?
We do practice the same strategy, but I would rather say Dr. Vena's tolerance to the hypercardia is more than us. We generally have of 7.2. 7.25 to 7.2 is our range. Beyond that, less than 7.2, we are not. By learning today, maybe we'll try to go to lower value. So I would ask Dr. Weiner, is it okay to go even lower than 7.2?
So that's a great question, and that's a controversial. And I think if you ask members of my division, you'll get some slightly different answers. I've reviewed the literature extensively, and in pure respiratory acidosis, so not metabolic acidosis, but pure hypercarbic respiratory acidosis, there are my review of the literature says that the hemodynamic effects of acidosis don't start until the pHs get much lower than 7.1 even. So I am very comfortable with 7.15. I'll go to 7.10. I will say that many of my colleagues in the pulmonary division are comfortable with 7.2 and they're okay with 7.15. I'm one of the more aggressive people in my group, but I think the notion is that if they're hemodynamically stable, I'll let that PCO2 go up. Remember, the curve of alveolar ventilation versus PCO2 at that point is almost exponential. So small changes in alveolar ventilation cause big changes in CO2, but CO2 diffuses beautifully across membranes and does not cause a paradoxical acidosis like metabolic acidosis does. So that's why I'm very tolerant of it.
Thank you both so very much for this interesting discussion. I'm going to move us right along in the spirit of ending on time and allowing our Indian colleagues to enjoy their Friday evening with their families. I just want to acknowledge and take a moment to acknowledge the amazing amount of work that went into this session, but also to acknowledge that each and every one of you, thank you for staying throughout the whole of our session. I see 184 people are still on the line. You know, this is an unprecedented humanitarian crisis, but it is an opportunity for knowledge sharing, for resource sharing, for developing better evidence-based practices and building capacity for essential emergency and critical care. And that's what we at RISE USAID hope to do for all the health facilities that have logged in today. To start with that in spirit, our colleagues here at Johns Hopkins University, Dr. Valerie Asula and Dr. Pavna Seth are synthesizing all the evidence that was reviewed in today's talk. You're going to get a comprehensive package of the latest evidence, a synopsis of the papers, other courses and training opportunities, and we'll also be collating information from our colleagues in India, as well as any relevant guidelines or protocols that can be implemented at your institutions. That will be distributed in about 3 days, so keep your inboxes open for Monday morning. Next week, same time, same place, we're going to be reviewing the prevention and the clinical management of mucormycosis. We're going to be joined by NGIMS in Maharashtra, and we have two colleagues, Dr. Kalantri, the medical superintendent from MGIMS Sevagram, and Dr. Sumit Jajo. This is a part of a 9-part series, which starts with mucormycosis. We'll move on to pediatric cases, and through pregnancy, palliative care, rational use, health worker resilience, and COVID-19 diagnostics and surveillance. As we move past COVID-19, as I said, the focus and the opportunity here is to build essential emergency critical care capacity. So we anticipate a follow-on webinar series, which will be another 9 to 12-part series, focused on basic tenets of evidence-based practice in emergency and critical care. All of this is brought to you by our Japaigo India RISE team. And I just want to put a shout out to Dr. Nuchiketa Mohanty, Dr. Parvez Menon, and Bijali Sinha. They have been working together and connect with each of the health facilities that are present here today. These are your points of contact if you're interested in finding out more about how RISE India can support you. not only in the clinical case management of COVID-19, but our scope of work expands to vaccine support, oxygen ecosystem support, laboratory diagnostic testing and surveillance support, networking and connecting across the health system. And many of you are aware of the extensive hub and spokes model that RISE India has built over the past year. I want to end promptly at 9:30 a.m. and I think it's 7 p.m. in India right now. Good evening, good night. Thank you so much for everything that you are doing. Please feel free to stay on if you have any additional questions or contact any of our RISE colleagues on this call. Thank you so very much.
Great job, everybody. Thank you very much.
Thank you, sir. Thank you, ma'am.
You're welcome. Please keep your inboxes posted and I'll see you next week.
Thank you so much.
Thank you very much, everyone. Wonderful.
Thank you, ma'am.
Thank you. It was a very illuminating session, ma'am.
You're welcome. I look forward to seeing you ongoing, and I'm happy to answer any questions and stay on the line for a few minutes.
Bhakti, I can stay on for just a couple minutes. One of the patients, one of the people asked about diabetes. Most of our patients also have
Thank you very
glucose
much,
intolerance.
ma'am. Answer.
Thank you. Dr. Weena, you were mentioning about diabetes.
Yeah, I would just say that most of our patients have, if not diabetes, at least glucose intolerance in our ICU2. And we treat with the typical low, medium, high sliding scales. If patients are requiring a lot, we will then put them on basal long-acting insulin. We do not use insulin drips routinely for most of our typical we do not use insulin drips for patients who are not in DKA, put it that way.
Thank you.
Can we share our slide? Bhakti will have, someone is asking for our sliding scales. I obviously don't have those, but we do have protocols in the ICU for low, medium, and high sliding scales.
We can put those into the Word document. I'm happy
Okay.
to do that.
Yeah, that's a good question. And I wrote some stuff in the chat about my tolerance for respiratory acidosis also.
Dr. Vainu, can I ask one question?
Sure.
Comment from generally in this case which you have presented, the invasive ventilation duration was 6 to 7 days, if I am not wrong. But
That is correct.
This type of patient whom we are managing, they generally go into close to 2 weeks, 10 to 14 days is. So what is in general, what's the opinion that, like from your experience, how we can cut their duration? Because generally we do proning, then see what they do in supining, and the requirement is there or not. Once we decide that there is no requirement, then we put them on a waning trial, SIMB, and then go for SVT and other things. So, so what is in if we talk about number, what percentage of your such patients you can get them out within a week time, or it takes generally 2 to 3 weeks?
So I would say that I would say our experience has changed over the course of the pandemic. Early on, it was rare to get a patient off in less than a week. And I do think that we've become better. And the reasons that we couldn't get them off in a week is that, in retrospect, we were over sedating them and we were not aggressive enough in lowering the tidal volumes, I think. I think we've become much more aggressive, as I pointed out, getting down to 3 or 4 milliliters per kilogram tidal volume. I honestly believe, and whether or not this patient was just lucky, I mean, I would say that this was the last patient I cared for. I did not make this patient up, but this patient did do better than most of my previous patients. He was able to synchronize with the ventilator pretty well. I was able to get him off paralytics pretty early, but we were very aggressive about proning him early and using very small tidal volume. I believe in ventilator-induced lung injury deeply, and therefore that's why I just try to keep the lung as minimally ventilated as possible. So, it's a good point. He was an outlier. He was. I would say most of our patients are intubated for 8 to 10 days is typically. So
more aggressive lung protection is what makes a difference. That is what I can take from this.
I'm hypothesizing that. I think, again, like I say, I'm very aggressive about lung protection, and I'm very aggressive about allowing permissive hypercapnia.
Thank you, sir.
That's just me.
One question to you. Yeah.
Yes, sir.
In this case, you said you allowed permissive hypercapnia to the levels of 85. So in our setup, what will you advise for such cases, and how long could we actually keep these patients on such PaCO2 levels?
So I allow permissive hypercapnia even higher than 85. I really do. Especially in a patient like this with good kidneys, he'll adjust. They adjust their pH over the course of 1 to 2 days, and then as they get better, we let them gradually come back, and as their ventilatory control gets back, we let them get it back over days. If it had been 100 and his pH was, again, I am the most aggressive in our group, or one of the most aggressive in my groups, but I'm very comfortable. If some of my colleagues who are less comfortable, when they see 7.15, but they want to really, or below 7.15, they give a little bit of bicarb. They do give a little bit of bicarb. But again, at the same time, I'm trying to keep these patients a little dry. So, but some of my colleagues will give a little bit of bicarb to allow those the permissive hypercapnia and keep the pH a little bit higher than 7.15. All of us are comfortable down to 7.15 though.
Thank you.
Thank you so much, everybody. So I'm going to close the Zoom link unless there's any burning questions. But what it shows is that the dialogue really needs to continue. We don't have all the answers yet. There's plenty of opportunities to do research, but also as the pandemic evolves and the variants evolve and our knowledge of how to manage these patients evolve, hopefully outcomes will improve as well. So we'll see you all next week on Friday to talk about mucormycosis, prevention and clinical case management. And if you have any suggestions for future topics or would like to engage with the India Rice team, please do not hesitate to reach out to us. Thank you once again, and have a great evening and a good weekend.
Thank you.